We're going to go straight into our next keynote speaker. I have covered the Care Quality Commission now for far too many years, but one thing I've seen it do is transform in the last 5 or 6 years under Sir David Behan's leadership, and with Sir Mike Richards as Chief Inspector of Hospitals, and of course his deputy as was, Ted Baker, who is going to be talking to us this afternoon about his vision for the CQC, but also what regulation can do for us and what regulation can do for improving patients. And I've seen the benefits of that, and I know it's difficult for a regulator. Nobody likes having the knock on the door. But I think Ted's going to have some interesting snippets and insights for us. So, ladies and gentlemen, please welcome to the stage Ted Baker.
Thank you for that, Sean. I'm not sure I like to be characterised as a knock on the door, quite honestly. That does sound a bit threatening. We are the regulator. We're not here to threaten people. We're here to help you improve your services. So please, don't go away with thinking that we're here to actually beat you around the head. I know a lot of reaction to regulation is a very defensive reaction. I'm going to come to that in my talk. But actually, what I say to every audience I meet is, I want to be partners with you in helping you improve your services. And that's what we as a regulator aim to do. And it's important to see us as allies in helping you drive patient safety. And I just want to talk a bit about my history in patient safety, and how I got to where I am, because I think that's an important context for you before I talk specifically about what the CQC's found and what we're doing. Now, before I joined the CQC, I was in various roles, but I was in clinical practice for 35 years. And during those 35 years, I was working at the front line, and I saw an awful lot of clinical incidents. So patient safety was something that really I saw everyday issues around patient safety. And in some sense, the frustrations about not being able to solve those problems myself is what drew me into various roles and eventually into the CQC, which is why I'm standing here before you today. I want to tell you the story right in the early part of my career, which is one that has always stuck in my mind about patient safety. And I think it really kind of gives a picture of really my thinking about patient safety. It was when I was a year out of medical school, and I was working in a district general hospital. I was the paediatric SHO on call for the night. It was the first few nights I was there, I was by myself running the whole of paediatrics and neonatal care in this hospital. Because in those days, there wasn't much support. There was a registrar, but he only did alternate nights, and he wasn't doing this night. And there was a consultant available at home who I found a bit intimidating. I was always cautious about calling. And I was called by a GP about a baby of about 6 weeks. And the GP said, "This baby's not feeding, can you have a look at them?" They came in, and it was one of those dark winter evenings. The parents brought the baby in, and they were smiling. They said, "She's better, she's had her feed, we think she's much better now. We think it's a false alarm." So I kind of sigh of relief, haven't got to deal with the sick baby. But I examined the baby, I was thorough, I examined the baby. The baby essentially looked okay, observations were fine. But just as I was lifting the baby up, a final part examination, you could feel a little judder. And if any of you are paediatricians, you'll know that one of the aspects you look at in children is how they handle, in small babies, how they handle. If they're not handling normal, if they don't have normal tone, normal reactions, that should raise suspicions in your mind that something's going on. So at that very moment, I said, well, I think we ought to run some tests anyway. I know you think she's better, but we'll run some tests. We did run some tests, and the baby was septic. And if I'd sent the baby home, who knows what would have happened. Fortunately, I kept the baby in, we put her on antibiotics, and she did very well. Now, that was when I was an inexperienced paediatric SHO. But it taught me a lesson. It taught me how fine the dividing line was between safety and danger for patients. How thin that gossamer string is that supports the safety of patients. And essentially, that's a real problem for people working on the front line if they work in an environment where they feel that they're expected to be infallible and never miss anything. They're expected never to make a mistake. And in many ways, that was the culture of medicine I grew up in. But in 1999, a report came out of the Institute of Medicine called "To Err is Human." And that, for the first time, raised the issues around the no-blame culture and about the need to focus on systems rather than individuals when things go wrong. And that was a revelation for me. And that was 19 years ago. 1999 that was published. So it seemed to be a big change at the time. So the question I always ask myself is, what have we achieved in the last 19 years? Have we got to a place where we recognise the real pressures on frontline staff to get things right, and we support them to make the right decisions and ensure patient safety is secured? And I suppose that is one of the reasons why I'm standing here before you today, to actually, if you like, explore that and work with you and other frontline staff to make sure that patient safety is secured. Now, the next issue that came up for me was when I was working as medical director of a trust, we had the mid-staffs inquiry coming out. And one of the things that really struck me about that was that there was a sense of, was the mid-staffs a one-off? And people were publicly saying, oh, this is just one-off. But actually, privately, what they were saying was, actually, there's a bit of that in us. I recognise some of ourselves in that. And so mid-staffs, these are some of the cultural issues that Robert Francis identified in that report: lack of openness to criticism, lack of consideration for patients' defensiveness, secrecy, and acceptance of poor standards. And actually, I think we all realised that some of that culture was there throughout the healthcare system, and we had to challenge it. And that's the reason why I decided to up sticks and come and join the CQC, because there is a real cultural challenge for us in the healthcare system to get this right. And one of the reasons I went into CQC was, if you like, to be part of driving that changing culture. And one of the things I found really exciting about today, and I've been here during the day today and gone to some absolutely excellent sessions, is there's a real buzz, there's a real feeling that this is about culture change. And so I want to congratulate you all on being here today, and I want to be, if you like, support you in the work you're doing to change the culture of the NHS so we can deliver consistently safe care. Just after mid-staffs, another report came out. This is a paper by Mary Dixon Woods, who I think is here today, maybe in the audience, published in 2014. And her team looked at 70 trusts and asked them about the cultural, if you like, the culture within those trusts, and asked them to speak confidentially about that. And she identified these points: systems, trusts, regulators, the wider system was comfort-seeking rather than problem-sensing. I heard an excellent talk about culture earlier on this afternoon, which touched on just that point. People wanted reassurance they were doing a good job, rather than challenge about they could do a better job. When organisations were challenged, they were defensive, and they tended to blame frontline staff for problems, rather than accepting the responsibility. And they demonstrated displays of compliance. Rather than getting things right, they wanted to be seen to be getting things right. Staff at the front line often felt helpless and powerless to make change. They could see the problems, they could experience the concerns, but they couldn't make a difference. And often when solutions were found, they were magical. Simple fit, quick fix, do this, do that, all will be well. Well, patient safety isn't simple. It is enormously complex, and there are no simple quick fixes. Now, if you want to sum up what we've found in many of our inspections around patient safety, those bullet points would do. We've now inspected every trust in the country, and we found lots of examples of this across the whole system. And initially, when we went into systems, we often found this desire to keep the CQC happy. I heard Bill Kirkup talking about it earlier on today, telling the CQC what it wants to hear. Well, the CQC wants to hear the truth. If you're just doing something to keep us happy, that will not keep us happy, I can assure you. Now, one of the things I said to my inspectors right at the start when I joined the CQC is, beware of the dashboard that has everything green. If you've got everything green, that means they're looking at the wrong things. It doesn't mean everything's all right. It means that they are, if you like, emphasizing the things that tell them everything's all right, rather than things that tell them what they need to improve. And Gosport, Bill Kirkup was talking about this morning. I won't say a lot about it because we're still, if you like, absorbing lessons from it. But and Bill's description about it earlier on was very interesting. But I just want to highlight 2 points from the Gosport report that I thought were important. First of all, in 1991, when some of the nurses raised initial concerns about the prescribing of opiates, initially they were listened to, and they had a meeting, and then they had a subsequent meeting where they found that they were, if you like, their concerns were being blocked. And they were told, raising these concerns has upset the doctor a great deal. It has upset the doctor a great deal. So don't raise the concerns because people find it upsetting. And that is so often happens when we produce reports on organisations where we find problems. The feedback we get from some sections is, you shouldn't say that because people are upset that you've said it. Well, actually, facing up to the truth and the difficult questions is really very important and fundamental in patient safety. And sometimes what we find will be upsetting. It'll be upsetting for us, and I can quite assure you sometimes our inspectors find it upsetting, but it's also upsetting for those at the front end. But actually, the only way to deal with that is to actually face up to the problems and deal with them. And this is one of the lessons from Gosport. The other lesson is, and it's there in that final bullet point on the screen, is that it wasn't just the hospital. The whole system let those patients down. And that includes the regulators. CQC wasn't there, but our predecessor bodies were at the time. And there's no doubt the investigations that were done didn't get to the root of the problem and didn't stop the problem when it should have stopped it. And we need to learn about that. We as the regulators need to learn about that. We need to learn the lessons that we react appropriately when we're faced with these concerns and don't, if you like, become part of a system that keeps the concerns, if you like, at bay. So this was a summary report of our inspections of acute hospitals, and it says safety remains our biggest concern. This report came out in 2017. It's still our biggest concern now. And if you want to summarize that concern, it is not that people don't care about patient safety. They do. They care passionately about it. But they don't translate that caring into consistently safe culture in clinical services. And what do I mean by a safe culture? Well, one where everyone takes ownership of the need for patient safety. They don't see it as someone else's responsibility. They see it as everyone's responsibility. Everyone is involved with that. And that's from the board right down to the front line. That people feel free to raise concerns without being penalised, without being criticised, and without people being blamed that things have gone wrong. So building that just culture that we heard so much more about earlier on today. And that there's a real desire to drive improvements based on that learning. A real desire to drive improvements based on that learning. And we support frontline staff to make a difference. And I think that is what we're looking for when we look at patient safety in trusts. And these are some of the details of some of the issues that we found in acute trusts. So I could put a different list for, say, mental health trusts or community trusts, but these are acute trusts. And you see top of the list is the deteriorating patient. So I'm very pleased that there's been a big, strong focus on deteriorating patients in this conference, because we see that as, if you like, the biggest patient safety concern we have. Now, about 4% of deaths in NHS hospitals we think are avoidable, and about a third of those deaths are due to failure to recognise and treat deteriorating patients, a third. So this is a very significant problem. I went to a session just before lunch on the News 2 and the implementation of News 2. It was an excellent session. It showed what good practice really looks like. But too often in our inspections, we go around and find early warning scores, or if you're being used in a tokenistic way. Forms are being filled in, but scores are not being calculated. And when scores are calculated, action is not being taken on them. So we need to move on from this sense that implementing something like News, or News 2 now, is a bureaucratic, paper-driven exercise. But actually, it is a real process and a culture around protecting the safety of patients and dealing with one of the most important concerns we have about patient safety. I could go down the list, I won't go through each one, but ineffective audits are absolutely, we see those virtually everywhere. We go in, ask about hand hygiene, and we're told we've got 95% compliance. Here's an audit that proves it. And you walk onto the ward and you can see it's not true straight away. People are producing paperwork, again, to keep the CQC happy or to keep the board happy, not to drive improvement. Now, we've known for 171 years now, that if you clean your hands before you examine patients, you save their lives. So why are we not getting this right? And why are people looking for paper compliance rather than actually driving the improvement that's necessary? I could go down the list. We could talk about safety training. I call it safety training. You probably call it mandatory training and regard it as bureaucratic, or some of your staff may. But actually, if we called it essential safety training, perhaps we would take it more seriously, because that's what it is. That's what it ought to be. I won't go down that list in total. It's all there in the report if you want to read it. There's not time to go through it in detail now. So you might say, well, this isn't a very good picture, but actually, since we started our inspections, services have been improving. The safety of services has been improving. There is still a long way to go, but meetings like this as an opportunity to express some real support for the work that is going on out there and pay tribute to the dedication of staff who are driving improvement. If you look at the overall ratings for all NHS trusts, in the last year, we've moved from the majority being requires improvement or inadequate to the majority being good and outstanding. And that is a marvellous achievement at a time when the system is working under intense pressure. And that is because of all the work that is going on at the front line, delivering quality improvement. It's a very important achievement. But we are still not where we need to be. If you look at the 8 core services in acute trusts, you will see that there's quite a variety in the quality we find in each of the core services. In the majority of services, we are seeing improvement. But in one particular service, A&E, urgent and emergency care, there at the bottom of the slide, we are seeing no improvement. In fact, we are still seeing problems. In May, we published the results of a report in March into urgent and emergency care, looking backward over the winter, but also trying to learn what we could do to improve safety in emergency departments across England. And this report pointed out our concerns about safety, and if you read our reports, you will see our concerns about safety in emergency departments. We gathered together 70 clinicians from emergency departments all over the country. We asked them, what are you doing to ensure your patients are safe, even when you're working under intense pressure? And they came up with many, many ideas. What was really important was an opportunity for them to learn from one another. And actually what was really encouraging in that room was to see them learning from one another and taking ideas away. We've incorporated all their ideas about how you focus on safety in this report. And the report is there and available on our website if you haven't seen a copy of it yet. There are 2 big messages from the report. There are more that emergency departments can do to improve safety, even though they're working under pressure. But the hospitals and the boards need to support them. When I wrote out to trusts about this report, I wrote to the chief executive and I asked them to make sure their board gave it attention. You won't be surprised that some of the emergency department consultants told us, well, actually, when you sent that letter out, they just sent it down to me and told me to sort it. The board didn't really want to look at it. Now, in that letter, I said, in your emergency department are some of your most high-risk patients. It should be a real focus for your board about where the clinical risk in your organization is. And I cannot understand why organizations are not focused on protecting safety at the front line, where it is most high risk. And that comes back to my issue about culture. Because I'm sure those organizations would say patient safety is our top priority. But actually, we've got so much on, we'll leave emergency department to the emergency department to run. But actually, in the emergency departments needs support. The other big message in this report, and it's an important one, is that the system pressures are getting worse year by year. And the only way we'll achieve sustainable safety is by system reform. We cannot just focus on it locally. And I think what has become very clear in the work we've done over the last year at the CQC is how much of safety depends on how well the whole system works, not just parts of the system. This report, Breaking Barriers, came out last week. And it is about the local system reviews we've done across 20 systems across England, looking at the care of patients over 65 and looking at how the health and social care systems work together. And what we essentially found is there are really no health and social care systems. They're individual providers who work together collaboratively in some places, but not collaboratively in many. And this is really a very fragmented system. And often the safety concerns are where patients fall in through the gaps between different providers, and they're not really receiving integrated care. So what this report says is it is essential that systems work together and collaborate if patients are consistently going to receive the safest and best quality care. I think it's a very important report. It has changed our thinking at CQC, and I hope you've had a chance to read it. You'll take it on board in your thinking about patient safety going forward. These are some of the solutions we put in that report, suggesting that the funding and performance management needs to incentivize the right high-quality care. The workforce needs to work together across different providers And you need to consider the workforce across different providers to make sure that you provide the right workforce in the right places. There's no point in a hospital recruiting more nurses if they're taking them out of the care homes and reducing capacity in care homes. Because all they do end up is having patients in hospital who should be going to care homes, for instance. But also we've challenged ourselves. How are we as a CQC going to react to system integration and working to make sure our regulation encourages effective system regulation? And that's something we're very much focused on going forward. Now, a couple more slides before I'm finished. Time is running out, so I'll need to speed up at this point. We're doing a review of never events. Now, you may be surprised to know that in the last 7 days, there have been 11 never events reported in the NHS in England. 11. Let me just get this right. 5 wrong site surgeries, 3 wrong prostheses, and we saw Keith Conrad's presentation on the problems of that earlier on, 2 retained foreign bodies, and 1 medication administered by the wrong route. That is just the last 7 days. There are about 500 of these a year. And I suppose the question is, why do we keep making the same mistakes again and again? And that's the question we're asking in our review. We're going to report in October on this. These are some of the detailed questions we're asking. Is safety really the top priority, or are we just saying that? And how do we get organisations to move beyond the slogan to the reality? Why does healthcare not recognise that it is high risk? I was at a meeting as part of this review with a group of high-risk industries, aviation, nuclear, offshore oil. And they said to us, we are high-risk industries. Safety drives everything we do. You don't hear that in the healthcare system. The healthcare system talks about itself as though it's essentially safe, but things occasionally go wrong. When are we going to recognise that is not a true reflection of what healthcare is? It is intrinsically high risk. How do we get that across so people aren't, if you like, doing the wrong site surgery? And how do we make sure that when there are clear safety protocols, such as the WHO Surgical Safety Checklist, that people are actually using it, and they're using it not just in a tick box form, but using it consistently to drive patient safety? When the WHO Surgical Safety Checklist was initially launched, it demonstrated virtually halving of operative mortality across 8 centres across the world. Virtually halving operative mortality. It saves lives. And yet here, I think it's about 9 years later, we're still fighting to get it thoroughly embedded across the healthcare system. Safety training, I've already talked about, and how well do we, if you like, balance the pressures on services with safety? I've talked already about urgent and emergency care and how we could balance that better. But that, of course, is true across many other services as well. If you want to understand how to drive improvement, I heard a session earlier on today about improving quality improvement. If you look at our reports on driving improvement, both in hospitals, mental health, and here in general practice, you'll see that it's mostly about culture and leadership. It is about providing the right environment for people to succeed. It is about empowering and engaging staff. And so often, remember when we started off, we talked about the NHS having a sense of powerlessness of frontline staff. There's a real sense, certainly in this conference, that staff are beginning to be empowered to make real change. The details of what we found in trusts that have improved are outlined, and you're going to have a session on that, I think, after coffee later on, so that'll be interesting to hear. Now, Sean asked me to say 3 things that you should do to take away from the talk. Here are the 3 things that the CQC is going to do. We're going to relentlessly focus on culture and leadership, because they are fundamental to driving patient safety. And I'm glad I've heard so much about culture today. We're going to use our regulatory powers flexibly and intelligently. And that means we're going to do it from an insightful view to understand what is absolutely required for patient safety, where we'll use our enforcement powers, and where we want to change culture, where, if you like, we'll use our influencing powers. Because we have a balance of enforcement and influencing. And we'll prioritise key risks. Next week, we're publishing a report on radiology backlogs, which is a key risk we've identified, which has long gone, if you like, not really focused on by the NHS. We want to push it up the agenda because we've found in our inspections episodes where backlogs have been allowed to build up and not properly managed. What can you do? Well, I think you should continue to focus on leadership and culture, as you have done in this conference. Please, can we get to a position where we all understand healthcare is a high-risk industry and needs to behave like a high-risk industry, and we need to accept the implications of that. And really, we can only deliver this by engaging and empowering frontline staff. Thank you.
Thank you, Ted. That was excellent start to the session. I've got these guys so well trained, I might leave them to ask all the questions, actually. But I'm going to go for one first, chair's prerogative. But a lot of people criticise the CQC for targeting its recommendations, its inspections at providers. Obviously, that's the legislation under which you work. But people say, well, I am driven to do certain things by politics, national bodies, what MPs say, what the health secretary dictates, what our commissioners require us to do, none of whom are regulated by the CQC, none of whom can be told they've got that wrong. Is that a problem with the regulatory model we have in this country? Are you targeting only one group?
Well, we regulate providers, we produce reports on providers, so clearly we give instructions to providers, and that is the regulatory model. As I said right at the start, I see our role as to be a partners with those providers in driving improvements. And for instance, sometimes providers have said to us, we can't change that because we're only commissioned to provide the service in this way. And so if you criticise the service, you're blaming us when it's not our fault. Well, if we criticise the service, we're not blaming them. We're just saying, from the patient's perspective, this service isn't right. And actually, we would like to see the providers taking that report to their commissioners and opening negotiations with the commissioners about how they could commission a better service. And likewise, we want people to use our reports, if you like, as evidence they can take to these other bodies to argue their case. And I think that is the potency of it. So if people, if you like, internalise our reports and see them as a criticism of them, rather than seeing them as an opportunity to drive change, I think that is really missing the point.
See the CQC as an opportunity.
An opportunity to drive change, yes.
So, as I said, I've got these guys so well trained. They've got lots of questions coming in on our Slido polls. So I think they'll hopefully pop up in a second. But the most popular one, with 34 votes from RS, says that in every trust I've worked for, prior to a scheduled or non-scheduled visit, the staff get very heavily briefed on model answers for CQC inspections. Do you think you're really able to see the reality of the trust? Which safeguards do you have to ensure it?
Well, we're on the trust for a few days. We go to a few places. We don't see everything. I mean, we as a regulator, we haven't got X-ray vision. So in a sense, we take a kind of temperature check of what's going on. What I have found is that staff are really very honest with us. And we find that the staff tell us exactly how it is. Now, it may be they are briefed, and it may be that some of the staff tell us what the briefing is, but I can assure you, virtually everywhere we go, other staff will tell us exactly how it is. And we rely very heavily on that information we get from staff, and of course from patients. So we don't just, if you like, rely on a very narrow bit of evidence. We rely on a very wide bit of evidence. And there are very few organisations where staff don't, as part of the inspection, raise concerns with us about this, that, or the other. And we incorporate that into our inspection. And often we'll go places because staff have said, you need to go to this ward because we're worried about it, and we will go there. So I think staff, if you like, are much better than you're making them out to be. And I don't think many staff will take a briefing and just tell us exactly what we want to hear. As I've said, we often can pick that up. And if we think we're being told what we want to hear, then we will regard the leadership of that trust, if you like, with some suspicion. What we want is trust that will be honest with us about their problems. Not that they haven't got any problems. We don't believe any trust has no problems. We want a trust that will be honest about their problems and actually explain how they're addressing them, rather than, if you like, try and hide their problems.
The next most popular question from a senior nurse, works across multiple sites. When we were CQC inspected, the same systems and policies were in place across the sites, but feedback and ratings were inconsistent and depended on the interests and experience of the inspectors. What can you do to improve your own quality assurance?
Well, I mean, we're always looking to improve our consistency, but I'm sure that's a fair challenge, and we need to learn from it. But having said that, I think we don't just, people seem to think that we rely just on the individual inspector reporting what they found. There goes through a lot of checks beyond that. So if there is difference in the two sites, then I'd ask people to look at, are there real differences between the two sites? Because what we don't do is just look at policies and procedures. We look at actually what's happening on the ground. And it may be things are happening differently on the two sites. I don't know, without looking at the details, I can't be sure. But having said that, sometimes people accuse us of being inconsistent because they don't realise that actually things are happening differently in different parts of their own organisation.
I mean, I think David Bean has recognised that you are aiming to be more consistent in your judgments.
I think that's right, and there's no doubt there's need for us to keep focusing on that, to be consistent, to get the right judgment consistently, and we're constantly testing ourselves on that.
Yeah. You spoke in your presentation about the improvements that you've seen through the process that you've been following. But it's right that the CQC this year have effectively allocated more resource because of modelling that there may be some deterioration in standards this year. That's correct, isn't it? Are you worried that you're going to see some decline?
The CQC has modelled the standards might deteriorate and that standards might improve, and we plan for either, quite honestly, Sean. So we're not predicting the future, we're just planning for any potential scenarios. I mean, clearly we have resources, and we need to make sure those resources are deployed most effectively to deal with the risks that we see out there in the system. So in the winter, we put more resources into inspecting emergency departments, for instance, and took them out of other areas which are lower risk. And, and we will go on doing that kind of approach.
But given the pressures that the system is under that you have highlighted in the state of care reports now, that are you worried that with the pressure on services, the ever-rising demand, the workforce shortages, all the challenge that we'll all be familiar with, are you worried that slight improvement that we've seen can't be maintained?
Well, we've seen quite substantial improvement, Sean, and I think we need to give credit to the people who've done it. But I think there is a tension in the system between workforce pressures, the financial pressures, demand increasing, and the need to improve. At the moment, I think I'm very optimistic because we've seen some really good improvement, even though there's been those pressures. But having said that, of course it's a concern. Of course it's a concern. And that's why we published last week the local system reviews, Beyond Barriers, because we think that the solution to that, first and foremost, is about system reform. We have to get the system right to make sure the patients are receiving the right care in the right place at the right time. At the moment, we're not delivering that.
Yeah. There's a question here that says, you state the CQC don't want audit results to keep them happy.
No.
Yet how do we demonstrate evidence of compliance? Without audits, trusts end up being criticised for a lack of...
We're not saying don't do audits. We're saying do audits with a purpose. Demonstrate how you're using that audit to improve your services.
So it's what comes afterward.
It's how you use the audit. I mean, the first question is, have you done an audit? The second question is, and what have you learnt from the audit and what have you done with it? And if you're not using audit as a tool to improve, then you're not using it effectively.
Okay, I'm going to crack on with the next question. Why the focus still on never events? Are we not prioritising what are rare events compared to other incident types and taking eyes off the wider ball? Focus on failure, why not on near misses?
I think it's a good question, and that's one of the questions we're asking in our review. As I say, I don't have an answer to that. We've been asked.
You can't tell us what's going to be in it.
I'm not going to tell you what's going to be in it. No. Well, I don't think we're still doing the review, actually, Sean. So it'd be foolish for me to speculate what's going to be in the answer. But I suppose one of the questions we will be asking is why are we focusing on just never events? But never events were meant to be an exemplar of where we know we can deal with a risk. Why don't we effectively deal with it? And I think that's a very good question to ask.
There's a question here from one of our patient representatives, from Jonathan Broad, who said there's a significant gap in CQC inspection teams. How will you engage patient leaders better in the inspection regime?
Well, we do speak to patients as part of the inspection. We speak to stakeholders as part of the inspection. I think getting the voice of patients as a whole is always a difficult one because inevitably there's a limited number of patients we can speak to. So I think if there are any patient advocacy groups with any particular trust, we'd be keen to talk to them. And as we put out our information about trust, we always put out an invitation for people to contact us. And I'd encourage any patient groups to do so at that stage.
There's a question here which I really like. It's resource is precious and finite. How do we convert our energy from the risk of over-regulation to enable innovation?
I think the solution to the problems we've heard today is often going to be innovation. And we as a regulator must make sure we do not stifle innovation with regulation. And people often will say to me, you know, we only do this because CQC insists, but actually that's their interpretation of our position rather than understanding our position effectively. We are interested in the effect of what they do. So if they're taking a particular approach because it was the conventional approach, we'll say that's fine, you're taking the conventional approach, evidence-based, we support that. But if they take a different approach, which is equally providing safe care, we will always look at that. We won't insist they do it by any particular predetermined route. So there's a sense of we don't want to stifle innovation, but people sometimes see the regulator as doing that. And if you are doing something differently and you can prove that it is as safe as effective as the traditional approach, don't be afraid of telling the CQC what you're doing and explaining how you make sure it is safe and effective. We will accept that. And
this has to be our last question, I'm afraid, but can the CQC really ever regulate safety into the NHS? It's always going to fail at that, isn't it?
You're a real optimist, Sean, aren't you? Real optimist.
That's why they have me up here.
The regulation is not the answer to anything specifically. It can be part of the answer to a lot of things. And I'm sure effective regulation is part of the answer to getting safety in the NHS really effective. It is not the whole answer. And I think sometimes people seem to see regulation as the whole answer to lots of problems. Regulation has a role in all these problems, and we want to be constructive in that role. But if people see regulation as the answer to all the problems, no. This conference is about changing culture of the NHS, and that's what needs to be done in order to drive patient safety. And I think it's really positive what I've heard today. But for us as a regulator, we want to be part of helping that culture move on, not, if you like, holding it back. But equally, we cannot change the culture by ourselves. It has to involve everyone. I think one of my earlier slides said patient safety is everyone's responsibility, and that applies across the board.
Okay, well, ladies and gentlemen, Ted Baker, Chief Inspector of CQC.